Welcome to our latest episode of the Lebanese Physicians Podcast. And today I will have the podcast with my good friend, Dr. Dany Matar, discussing virtual cancer clinics. I mean, that's a thing, I guess, that people have been talking about, but this is now has been developed, actually. We will discuss it today with Dr. Dany Matar. So, Dr. Matar, welcome to the podcast.
Thank you. Thank you for hosting me. I'm looking forward to the conversation.
So I know you work at the company called Color, as we can see, Care for Cancer Reinvented. But can you first, before we discuss your work at Color, can you just tell us a bit about yourself and how you ended up at the company?
Yeah, I'm a physician by training, actually. I was born and raised in Lebanon. I went to medical school I went to IC for school, and then I went to medical school at USG, Université Saint Joseph. And after I finished, I came to the US. I did a master's in public health and also some research. Actually, it's random, like a nephrology transplant research at Johns Hopkins. And I wanted to spend more time less so on the front line of actually taking care of patients, but thinking more how you can change the healthcare system in a way that better serves the patients and the people who go through it. So I spent 5 years at McKinsey and Company as a consultant after my MPH, and then I've been at Color now for 6 years, where we've been building this virtual cancer clinic. Yeah, that's a little bit of my journey. I feel like this has been a very exciting part of the work I do because it's a new way of delivering care for patients who have cancer, and that actually we think can make a bigger difference for many people. So that's a little bit of my journey there.
Right, cancer. I mean, and you're a good example of people actually who did medical school and then ended up using the medical degree, but to different
Yeah.
needs, and not necessarily to patient care itself, but potentially to maybe important things for patients too at this point. So, what inspired the creation of Color's virtual cancer clinic? Like, how did this come into
Yeah.
to be born?
Yeah, no, great question. So when Color's mission and the way we think about our work is we want to deliver the best medical care that science can provide today to as many people as possible, basically. And our belief is, there's a lot of ways you can change the way care is delivered that maximizes the impact of all of the science and innovation in healthcare and in medicine. I think a few years ago, you start saying, well, we're calling it like a triple wave of that in cancer that's making cancer like like an increasingly large problem in public health, but also in for the population and across the world. One, it's getting younger, so people diagnosed under 50. The percentage of people that are under 50 is increasing over time. So you have more people getting diagnosed. They're getting diagnosed earlier. Actually, there's 14 cancer types that have a higher incidence among people under 50 over the past 10 years than they used to before. The other thing is with the innovation in in medication and treatment and in immunotherapy and precision medicine, you have a lot better treatment, but are also a lot more expensive and a lot more complex. So what used to be more simpler protocols in the past are now becoming more complex and a lot more tailored to the patient, to their diagnosis, to their staging, to their tumor markers. And they're also a lot more expensive. So it's making the system harder because, first of all, it's a high financial burden on the patient. It's also very costly on the plans and the payers who pay for the medication. But also it's more complex. So if you think I'll give you an example. I think 55% of patients in the US, for example, see a community oncologist for their care. And so you want them to believe that all of those community oncologists are able to, flow all of the complexity of care for any diagnosis, any type of cancer to their patients and treat them effectively. And that becomes harder and harder the more complex the disease is. And then the third piece is people live a lot longer now with cancer. So you have survivorship rates are very high. For many cancers, it sort of becomes like a chronic disease, right? Like you're taking maintenance medication over the course of your life. But also as a cancer patient who lives longer, it's a very different, you know, nature of health you have, right? Like you have more chronic diseases, you have side effects of your treatment, you have risk for other cancers. And it will stress the system because you don't have enough experts in oncology or in survivorship, neither in the oncology setting or in the primary care setting. Like, there's no training in survivorship or fellowship in survivorship for a PCP. So you have now a much bigger population of people who will live with cancer and with the consequences and long-term impact of cancer on their health and their lives. and they need care, and you don't have the right setup to support them. So if you think about these trends, it's creating this compounding effect on the system where it's harder to access the right expertise all the time for all the patients. It's more expensive and very, very expensive actually for many payers and health plans and employers who pay for it. And so it's stressing a lot the financial burden of cancer. It's also very expensive for the patients too. And then it's also making it harder to manage a growing workforce who have a history of cancer, basically. That's what sort of took us into that direction. And we felt like you need a different way to think about cancer care when you have all these trends happening together that tries and scales the access to things that are today very hard to access for most people and are very, they rely on where you live and how close you are to a cancer center and how easy it is to access it, which is not the right way to support, a growing patient population.
Right. So yeah, what you're saying is the patient population is getting diagnosed at a younger age, and people should not forget that in a lot of areas in the US and even over the world, people live in small communities where they don't have the availability of at least a cancer center, maybe, and even if they do, they might not have specialized cancer
Exactly.
doctors, especially these days where it's becoming more like individualized treatment of the cancer,
Exactly.
a specialized doctor for each cancer. So maybe having a virtual clinic could lead to be able to access to that care. And obviously, you're very passionate about this issue. So my next question for you is why? Because you joined, I think, the company, if you told me 6 or 7 years ago, which is before COVID hit. So that was before telemedicine was such a big thing. So what made you decide that you want to join the company?
Yeah, so when I think it was really the mission, like, even because before COVID, even like, we were mainly supporting, cancer genetic risk and risk assessments and genetic testing for risk of cancer. That was what we used to do. And we also had a stint during COVID where we were very involved in the response and we helped state governments and federal governments across the country support the response to COVID, including testing, vaccination, treatment. Uh, I think the thesis for the company and why I joined was this mission of there's a better way to deliver care and to deliver the best that basically medicine has today to patients across the country. And it's actually a true problem. Like if you actually think about, how the time it takes from like new medications, new guidelines, new innovations to flow into patients, getting it consistently everywhere and reliably, it's actually a very long period of time. And that's all a missed opportunity for everybody who could have taken that medication or that treatment. And that's consistent across all disease areas. Like you see it in cardiovascular disease, you see it in cancer. There's just like a big lag between innovation and guideline changes and protocols and to when they get to all patients basically. And that was our premise was you can actually completely change that when you combine technology, telehealth, and the way you manage expertise, like like low availability but high cost expertise, like genetic counseling or oncology expertise or other expertise. So that was our thesis, and that was the mission of the company, and that's what I was passionate about when I joined. And we consistently did that. So we did it first in genetics. Like we had like our genetic test. I think we were the first company that released a clinical genetic test at a $250 price point, basically, which was extremely low, but completely changed the access for patients when you do it at that low of a cost. And also with access to genetic counseling, which was a very hard resource to find from a capacity standpoint. COVID was the same thing, right? Like you had tests, you had treatments for COVID. I don't know if you remember, but when Paxlovid was up, it was sort of the same thing. It was very low capacity because they didn't have enough supply. You need to take it within 2 days of your diagnosis. And so we built a telehealth system that allows you to speak with a provider anytime, 24/7, 365 days a year within 20 minutes. And so now everybody could get access to the drug way easy and way cheaper. So that's a little bit of the mission, and that's why I joined. And I feel like we're doing now the same thing with cancer, basically, and which has been exciting.
Yeah, basically having people like access care quickly, or even if they have questions, potentially be able to
Yes.
answer some of the questions quickly or get
Yes.
second opinions in that case. So you developed now, probably you just released it this week, I think, and this is probably one of the first virtual cancer centers in the country, right? I don't know if it's in the world, but in the country at least. Uh,
It's yes. It's so and we it was we ASCO, the American Society of Clinical
right.
Oncology, is the the most prominent organization for cancer care and cancer guidelines and quality. And they have a certification that they've been mainly doing for brick and mortar oncology centers across the country and across the world. And they have very strict standards of what makes a quality oncology care. And what we believed is actually, again, if you believe you can do that care much better virtually, we want it to be held to the same standards because we want to deliver great care for our patients. And so we went through the certification with them. To your point, what you said, we're the first and only virtual clinic to get ASCO certification, which means like, if you're a patient coming to color, you can trust that, there's high bar for the quality of care you get, the consistency of the care you get, the multidisciplinary nature of the care you get. And ASCO holds us to these standards now, and we hold ourselves to these standards. And yeah, we're the first virtual clinic to have done that. And also we're the first one basically then that can serve patients across 50 states, right, by design, because we can cover the whole country.
Right, exactly, because you're just a virtual cancer center, so you can see patients in any of the
Yeah.
states, I guess. But and ASCO certification, correct me if I'm wrong, also includes clinical trials, right? Access to clinical trials for patients.
Yes,
So that's good to know.
and that's a very big standard in oncology care, right? Like you want to make sure patients have access to or know that, like, are aware of clinical trials that they may be eligible for and have access and opportunity to enroll in them if they can. And obviously it's mainly because this is a very evolving space and there's a lot of new drugs coming to market and those are making a big difference. So, but that's a thing that actually doesn't happen. I think less than 10% of patients who are being given an option or they get an option to participate in a clinical trial, or there's a review done to make sure they have one that they could be eligible for. So we had to demonstrate, and we do that actually. Like we look at clinical trial options for every single one of the patients who come to color, and it's part of our standards. It's part of the expectations of that we set our team on and our patients. And when there is an opportunity, we talk about it with the patient and discuss it with them and help coordinate the enrollment if they actually want to or they're interested in enrolling in one.
So what, I mean, how do you guys convince ASCO, I guess, because this is like a completely new vision. And I bet it was probably hard to get ASCO to accept to give you certification. But obviously you're doing such a big thing that they're accepting. So what were the biggest challenges, I guess, in achieving
Yeah, no,
certification?
it's a great question. I would say first, like ASCO is like, it is a great organization. And I think also an organization that's very aligned in the need for great patient care and great outcomes in cancer. And I think that's where we're both aligned. We want to give the best care for our patients and make sure every cancer patient can get the best care they can get. And I think so that's one. Two, we obviously spoke with them about the model and why it needed, like, and how it could be a different way to deliver care. We asked them to hold us and they held us to the standards of any cancer clinic. And so, and I think that's really, we had to go through the full audit, they do a comprehensive audit. They also, chart reviews, documentation review, process reviews. They looked at our templates. They looked at the deliverables. They looked at how we operate and how we support our patients. We went through the audit with them. And actually the audit was great because it's not just for us to demonstrate that we're doing well, but we improved ourselves and we are today better because of the audit. Because like any audit, you learn there are things you want to do better at, and we're doing them better now because of that audit. So we were audited comprehensively, and we were held to the same standards. It was interesting because we were the first sort of virtual clinic that goes through the standards. There were a few places where maybe we had to do some adjustments on the standard, or even we proposed to them even some standards that are more specific to virtual care, because there's things that happen in virtual care that may not be relevant in brick and mortar setting, and they made sure they also assess us on those. So it was very collaborative to think through how we make it work, but at the end of the day we had to demonstrate that we meet those standards, and they did a full audit like they would have done to any center to get that done. And yeah, we passed it basically, and that's what got us to the certification. So, and that's been really the litmus test for them, basically, that we can actually do the right work the way they expected.
Exactly. And I mean, this is a new model. So as you said before, you're seeing patients nationwide. How do
Yes.
you ensure like quality and safety in a
So
nationwide
honestly,
virtual
this is
oncology model?
yeah, it's a great question, and this is really where like I do feel like this model makes a big difference. Well, today with technology, expertise should not be like, if you think what's hardest right now in cancer is it's going to the experts, and the experts are rare. There's not many of them. And really, it's how easy it is for you to get to them and see them in the right amount of time. But with technology today, you can expand the impact of expertise through technology because it's knowledge, right? It's knowledge, it's understanding of specific cases. An expert in prostate cancers knows prostate cancers really well and sees the failure points and what doesn't work with the patient. You can you can sort of democratize that. Like it doesn't in a virtual setting. We have a expert network and where we brought in experts from every single cancer, every single type of intervention in cancer. And they weigh in with us on the protocols we develop, how we assess our patients, how we treat our patients. And so it allows now for any patient to come to Color to know that the way they're going to be treated at Color is actually based on the expert guidelines, and not just on the guidelines and the evidence, but also the expert input of the best leaders in the country when it comes to their specific cancer. And you can expand that virtually with technology because that's what we built. So like our clinicians and oncologists, we see our patients, like they have the tools to be able to see that, to parse the patient's record, map it to guidelines, understand the differences, where there are gaps, make sure we're making the right decisions for patients. We build these tools for them that allows us to make sure no matter who's seeing you at Color across all of our team, wherever you live, all the same guidelines, the same protocols, the same best evidence recommendations are being applied to you as a patient in your care. So you're always getting the best care possible.
Right, which is a good segue into AI, I guess, because
Yes.
probably you're using AI in democratizing and making sure that the cancer models are equal among patients,
Yes.
whether it's in a small town in Arkansas or in a big city like New York, I guess. But
Yes.
how is AI being integrated into cancer screening and the treatment of workloads for these patients?
Yeah, so there's a few ways actually. One, I think the most impactful way is we're using AI today to empower our clinicians to be at the top of how they provide care to our patients. So if you think about a cancer patient, you have all of these medical records that you need to review for them on what they've been getting in care, where they are in their journey, what happened to them. And then you also need to understand how does that map to the best care and guidelines for their cancer that they need to have. And that is actually, it's a lot of, if you think about what AI is good at, it's really good at taking unstructured data, making it structured, and then helping you reason through it basically. And that's what we built for our patients, for our clinicians. They have this tool that actually, takes the patient's records. We interrogate those records in a very specific way, and we're looking for specific things based on what we know may or may not be needed for the patient. And then they flag to our clinicians, here are the things that you should watch out for this patient. Here are things I found that are a risk for them. Here's what the guidelines recommend for the diagnosis. So it gives the physicians a very quick way to get a sense of like what the patient's at, but also a way for us to ensure the quality, to your question of like how do we ensure quality, to ensure quality of the care for everybody. Because now there's something that's flagging in our systems when there's some departure from what we think is the right care or the right quality outcomes. And that allows us to act better proactively with the patients. So these are happening, also passively. Like we have alerts that the physicians can see when things go off, or and we also have, sort of like the integration into our patient's charts where like we're making sure there's like an easier way for the clinicians to get a full understanding of the patient's record and how it maps to guidelines. And then we built this, and then we also brought in experts to weigh in on the protocols themselves, on the guidelines themselves. So you sort of made the knowledge like more easily accessible for the physicians and a lot more tailored to every patient they're seeing. And that's what AI is able to do. And then it allows our physicians to be a lot more impactful with the patient, but also spend most of their time actually with the patient rather than like doing all of the admin work on the back end of like sifting through records and writing down documentation, etc. So that's been like the highest impact I feel of the work we do in AI and where it made a big difference for our patients today.
Yeah, which is great because I think one of the things I struggle with because I like do interventional pulmonology and sometimes I get referrals from oncologists and I'm looking at the charts and it's like patient diagnosed 2015 CT scan, whatever, and then you can't understand the whole note. Like you're like, what
No,
happened?
yeah,
So if you get an
yeah,
AI-based summary, that's going to tell you exactly what happened, and then you can spend more time talking to the patient rather than reviewing
yeah,
the records in that case.
yeah. Yeah, exactly. And we invested a lot in like what are the exact questions you want to look at in the record and we found things like we had patient, where, they fell 3 times in the past month, but then, somehow it wasn't really acted on, but we saw it in the records, and then we're like, okay, actually, this is a high risk patient. And it was because of the neuropathy from the chemo. So it was like, okay, like we need like this is the high. Like if you fell 3 times, like you're like one more fall away from having to go to the ER and having a breaking your hip. So our tools help us see this and then act on it. So we make sure the patient is well managed, so that doesn't happen.
Yeah, exactly. And one of the things in your press release, which is important too, because a lot of times like I have patients like where you do a bronchoscopy, you diagnose them with lung cancer for a lung nodule, and then wait like a month, get their breathing tests, then get their PET scan for staging, whatever. But you guys said that you had a 66% reduction in time from abnormal screening to treatment initiation. How did
Mhm.
you achieve that?
Honestly, this is like maybe the best example of like where the system breaks today, because when you have like take the bronchoscopy example you shared. Think about how many people need to be involved to get that patient from that abnormal finding you had to the diagnosis. And the level of coordination that's needed to get that to happen is very high. And we see that. There's another stat that I would share with you that we see very commonly. Roughly like 40% of the people who get an abnormal fit test, like a positive stool test, basically, 40% of them do not get a follow-up done within the next 6 months on that positive stool test. This is a patient who is like the screen is saying there's a potential risk for cancer here, and they don't get a follow-up within 6 months. And like this is the problem today in the whole system because of that coordination problem. We actually we basically what we did is we basically built a very specific workflow on how we manage every abnormal result we see. The moment we know somebody has an abnormal fit test, it's like we're all hands on deck with that patient to get them do whatever is needed to get them to their colonoscopy as soon as possible. Or if it's a mammo and they need a breast biopsy, to get them to the biopsy as soon as possible. And that includes, calling the facilities, moving appointments for them so they can get to the facility quickly. Or if that facility doesn't have an option, finding an option where they can come back quickly and get their colonoscopy or their biopsy done. Figuring it out with the patient. And actually, I think that's also like a very important part. Like patient, we all have lives, and I'm sure, you feel that, I feel that, like taking time off work and coordinating your life to go and do something unexpected and quickly is hard for many people, especially if you're a shift worker or like you're and you're critical for what you're doing every day, or you have kids at home. So we literally work with the patients on these things, like what do you need to be able to go and do this quickly so you're not having to wait a long time. Sometimes we end up coordinating transportation for them. Sometimes we are literally coordinating daycare. Like, let me see if you have a backup daycare through your work, and I'm gonna get you that coordinated so you can go and get this done. Or if you don't have a driver to take you, we'll find you a driver. But you need to solve these problems because this is why people don't go and do it. Like it's the level of effort needed by the patient and by a bunch of folks to get you from an abnormal to a diagnosis is so high that just things get lost in the process. And we just, we hyper focus on it and we make sure people do it. And we've had patients, even faster. Like I think we had a patient who, from literally the first day we saw her to the diagnosis, it took 14 days because we were very concerned about her breast symptoms, and we needed to get that done ASAP. But it took all of that coordination. Like we had to find her transportation to the facility. We literally had to manage around the scheduling of the facility because the people were off, etc., to get her quickly. But it took a lot of effort. But time is of the essence in cancer. So like you just need to do it, and you need somebody to feel accountable to doing it. And that's what we do. Like we're accountable for getting that done and done quickly because it's one of the key things for you to get treatment fast.
Yeah, and obviously, I mean, AI plays a role because let's say from my field, like you get a CT scan with a lung lesion or lung nodule. If you don't use AI, you might just forget about it. Like it's like the radiologist reads it, follow-up scan in 3 months, and nobody does that because you give the patient a number, they never call, and as you said, they're very busy. So what is the role? I think you have collaborations with organizations like OpenAI, Google, and stuff
Yeah.
like that. How does that play into the work that you guys are doing?
Yeah, we've done a few things today, I think. And so so as I mentioned first, like we've built tooling for our care team to better provide care for the patients. The two other things we did, and those are some of the collaborations you can see. One, like with Google, actually, we built maybe the other aspect today of care in cancer is cancer is no longer like black or white, or cancer risk is not black or it's very nuanced, right? Like if you look at your family history, your personal history, maybe some of your genetic data too, people are on a spectrum of how big their risk of cancer is. And even the screening tests are moving this way, right? Like if you do, especially some of the new technology in screening. So what we build actually is like, what is a way for patients to quickly understand what their risk is? And what does it mean for what screenings they need to do or how they need to be managed? Or to your point, how quickly we need to act on an abnormal result for them. That's what we did with Google. So last year with Google, we launched for Breast Cancer Awareness Month, a breast cancer screening tool and it's actually live and at no cost. So like anybody, who wants to send their patients that they can do, but it's a screening tool where patients can go and literally within 5 minutes, they can know what is their risk of breast cancer and what does it mean for what they need to be doing from a screening standpoint. Do they need a mammo? Or do they need something else, or are they up to date? And then actually and then the actual service of helping you get that appointment done and get your screening done if you need it, because again, that's what matters at the end. But again, that's another example where you can use technology to give people a very quick help in understanding where they need to be in that journey and educate them about their risk of cancer, because that's something that's not very often discussed. Like you don't talk a lot about it with your physicians, with your family, but there's a lot of actual data and evidence around it. So we help them understand that risk really well based on the evidence today and help them support them with it. That was another AI use case we built. We built it with Google. And it's still available, like patients actually can use it, but it was a way for us to help patients quickly understand their risk of cancer, which we think is going to be a very critical way to manage cancer and cancer risk over time with more as you get more diagnostic tools and technology. And radiology is a big one to your point. Like today, there's a lot of data of how AI enhanced mammos, for example, are like have better outcomes in cancer detection than just regular mammos. And so like these tools are going to start going in, and we actually look at those when we look at where we send a patient, what type of screen we're doing for them. We look at these things and make sure these are available because they make a big difference in the care for the patient.
Right, exactly. And so, yeah, AI has a lot of benefits. Are there any cautions, or what should we be cautious about with the use of AI
Yeah,
for
I,
patient
I
care?
I think maybe two things I would say. One is it does take a lot of intentionality in how you want to build these tools. Like this is not, I'm gonna just take an agent or like and then talk with it. You have to be intentional to make sure you get to the right outcomes because, you know, with AI, like what matters for you is not that did it answer me right one time, right? It matters to say, is it doing the right thing 99.99% of the
Exactly.
time?
Is it consistent or not?
Is it consistent or not? And that actually takes work, and that takes work, and that takes a lot of thinking in how you build it, how you build structured versus unstructured parts of your model and your software and your workflow. It takes us a lot of work to do that, and they think of it intentionally because you want it to be consistent and trustable and reliable all the time. That's the most critical piece. And so that's one thing I think that we've been very focused on and work on closely and effectively. The other two is what I see a little bit sometimes is you want to think what is the best, like I still think today the best impact that our clinical team can do is when they talk and work and educate our patients, because it's the highest value part, and it's the part that actually unfortunately I feel like in traditional setting you have less and less time to do. Like you're given 15 minutes to talk to your patient or 10 minutes and then you have to go to the other one, to the other one. I think what we try and do, and I would say is something we should think of, is you want AI to empower and maximize the time that the clinician can take with their patient, not replace what they do with their patients, because that's the highest value interactions you have. Patients trust their doctors and they want their doctors to be here for them, and they want their doctors to have the time to spend with them and listen to them and talk to them. And that's been hard in our system today because I feel like, you have to go through volumes. If you can maximize that, like that's a better use of AI. And that's, I think, where we can, my belief is like where AI is making a big impact today for patient care. So those are the two things I think about, like how you think about it as something that is really augmenting your clinicians and allowing your clinicians to spend more and more time with their patients, talking to their patients. And two, just like you want to build something that's reliable, and that takes a lot of focus and intentionality, and you need to segment these problems into small ones and solve each one of them. Like there's no magic AI agent that's going to do everything for you,
Right.
right?
And I compare it to like you're a physician out of your fellowship, right? Out of training, you learn every day. And AI is the
Yes.
same thing. The more you use it, the more it's learning and the less mistakes it's going to make.
Yeah, and the
Um,
quality is getting much better. Like the tools are getting much better.
right, exactly. Exactly. One of the promises of virtual care is like you are going to expand access, as you told me before. Who do you think are the patient populations who would benefit the most from your model?
To be honest, I mean, clearly, to your point you said at the beginning, if a patient lives in a place where they don't have access to expertise or to a cancer center, those are by design the people who would benefit the most. What I would say, and what's been interesting and also a little bit surprising to me as we treat our patients, we're like we're seeing impact on patients across all different types of geos or no matter where they are or where they see. I think, and I'll tell you why. I think because one, again, it is very hard for you. Like virtual care is so convenient for you. Like if you can, like think of it like if you can talk with your oncologist within a day or two of when you feel you want to, anytime, it's a completely different paradigm of access than today, where you have to be held to these very fixed times. I don't know, every 2 weeks or something, and they're very fixed in time. So we're seeing patients even who go to like big cancer centers or important cancer centers coming to us because either there are things that they haven't had the time or they can't be talking with their oncologist about because again it's a very fixed amount of time they spend with them, or like we're even seeing misses. Like we had a lymphoma patient who had a splenectomy and somehow they're made and they are at a major cancer center and somehow they missed that they need like you need now a pneumovax like every year, right? Because you're at risk,
They
and it
need
was missed.
vaccine, right?
Yeah, they didn't do it. So they weren't doing the vaccine, and then we caught that. So I would say true, like generally people with harder access are the ones who benefit the most because or people who have a heart like who live in areas that are low, that have low healthcare like availability generally. Like those are the people who benefit the most. And also it happens sometimes that these are the same as low sociodemographic areas or people where the English may not be a first language. Virtual is really great with these options because we solve all of these, right? Like you can call, we have a live medical interpretation line, so you can talk any language you need, like 200 language covered. So those are the people who benefit the most. But I am also feeling generally that even people who may be well served in where they live and how they live are actually getting benefit from this because there's always something you feel like you may not be getting or haven't had time to get in your cancer center. We also have a lot of supportive services, right? Like we help with mental health, we help with financial hardship, we help with nutrition, we help with return to work and leave planning. When you have one place where you can get all these services at once, you will benefit from it and you don't need yourself to worry about it or coordinate it across many people. So that like we're seeing people from everywhere come, but yeah, that's how I think about it.
That's basically it's like a virtual nurse navigator. Like
Yeah,
it
yeah,
does
exactly.
everything and then it follows
Yeah.
guidelines. So, but as you mentioned, like some of the people who benefit the most are the ones in rural or underserved areas, but these are also the same people who actually may not have as much access to technology. So are there any barriers to the care of these patients and how do you overcome them if they are there?
Yeah, it's a great point. We had to think about this a lot because obviously to your point, like technology is a barrier when it comes to virtual. We built the model to be sort of multi-channel. So you can talk to us you can talk to us on the phone. You don't need to necessarily like go online or create an account like or log into a Zoom conference. Like you can talk to us on the phone. You can also start anything on the phone. Like, we do have an intake, etc. They're all digital, but any of our digital intakes can start also with a phone conversation first. So like you can call our team and we will go through the intake together with you and we will create your record together with you and then route you to the oncologist to talk to you. So we built phone-based options for the patients intentionally so they don't really feel like they have to be always using a digital tool if they don't have it or they can't access it. The other thing is even our digital app is designed in a way that's more accessible to patients. So you don't, you need the browser. All you need is a browser. You don't need a fancy phone or a smartphone. You just need a browser to go in. Everything is like, we review everything to make sure like it can be understood by like a seventh grader. So like we do these things to make sure it's easy to access. And we have live medical interpretation. So if you don't speak English, you can speak in any other language. And those work in a video setting or phone setting. So they work in both. We've done these things to help people, to your point, if they can't access digital technology easily. And we work with a lot of population that are actually on the road. Like we work with truck unions, we work with, oil and gas people working in the rigs, we work with manufacturing facilities. And so we were by design had to solve for these problems. Otherwise, we wouldn't have been able to support these populations.
Right. Nice. That's a good, yeah, that's a good answer. Actually, I tried to catch you off guard, but you made it.
Good.
So the clinic performs multidisciplinary review of, you said 100% of the cancer cases.
Yes.
Why is this important, and how does this differ from currently? Because like before I just went on with you, I
Yeah.
had like our lung tumor boards. So how does
Yeah.
it differ from the traditional tumor boards, I guess?
Yeah. Well, so how many patients go through tumor board? Like not all of them, right? Like
Not
you
all of them. It's
select.
just a choice. Like I submit the patients, or the oncologist
Yeah, you
submits
submit
patients,
it
and we review the
exactly.
ones that we submit.
Exactly. But tumor board is what? Is a discussion among experts about the best way to treat a patient.
Right.
So like, but all that knowledge exists in your brain, in their brains. Like, so there's no, that was our concept of like, if you have a virtual setup with technology, you can give 100% of your patients a tumor board review because you can bring those experts on the specific questions that you are weighing in on, or every single part of the tumor board process weighing in on. You can build a technology that allows to make sure, that the basics are there, and then we're discussing the complex above the basics and the things that are more tricky together. So you can now create a system where everybody gets this multidisciplinary review. And we have it. As I mentioned, like we have experts in every cancer. We have experts in, also every interventions. Like we have radiation oncology experts. We have experts in CAR T. We have experts in, different types of, surgical interventions in cancer. So we have a drug, like a pharmacogen, like a cancer pharmacy expert for drug gene interactions. We have a mental health expert, we have a cancer risk expert, we have gen counselors. So you can now create a model where you do that way more efficiently with technology and use your experts for the most critical questions related to the patient's care. But you can do it for all patients because of technology and the fact that you're virtual. So a lot goes into this, right? Like we are pulling the records, we're organizing the records, we're making sure all the right questions are asked. We have protocol, the questions and the protocols are all built with our experts. So basically, and then we provide them with these summaries, and then they can weigh in and give us the right input for the patients. It now gives, like, again, to your point, like it gives every patient the ability to get the right care that is with multidisciplinary input, instead of having to do it just for whatever the 3 to 5% of cases that are being raised to a tumor board in a brick and mortar setting.
Right. Basically, it's like experts along with AI, I guess, summarizing the case is what helps out with this. So now you did the multidisciplinary care. You decided I'm going to treat the patient with, let's say, radiation therapy or chemotherapy. Obviously, this cannot be done virtually as of yet.
Yes.
So
Yes.
how do you coordinate the care with the local oncologists and the healthcare
Yes.
systems?
So two things. One, we work very closely with the local oncologists, like and we're for every patient we reach out to them. Our oncologist speaks with their oncologist, and we're tracking the cases with them together. We also have some systems integration that allows us to see the records of our patients and make sure we know what's happening with them. What I would say, like, maybe there's two ways I think about that question for you. One is we want to make sure our patients are getting the right care, and that's part of what we do. Like if a patient comes to us and doesn't have an oncology team, and they're like, okay, where should I go for my surgery or for my treatment, we have our own approach to deciding that. Like we look at the quality data and quality metrics for different cancer centers and different oncology clinics and expertise in specific cancers, and we would recommend something to the patient based on those quality metrics that we know is a reliable place for them to get their care or to get their surgery. So that's when we are trying to send somebody somewhere. Now, when we're working with the teams, yeah, it's a very close collaboration. We actually have relationships now with most of the big cancer centers in the country, and it allows us to do quick referrals when we need to. So if there's a patient who needs care, we can do quick referrals. We have, our care teams work together. So our oncologist knows like the oncologist in the centers, and we work together. Our nurses know the nurses as well, and they coordinate together. So yeah, that's how we do it. Like, so it's basically building those relationships with the cancer centers and being intentional where you want to send the patients, so you know that they're getting great care if they need a surgery or a
Right. Especially
radiation.
when you have the relationship, then you know who's the best oncologist who locally can take care of the patient, and you can send the patient there to get that care
Yeah.
that's needed.
And I feel like that a little bit too. Like there's always like physicians between themselves, they know reputationally like
Right.
the great people, and so it's
Yeah, you steer your patients towards
yeah,
those people,
yeah.
unintentionally or intentionally, I guess. So the clinic reports like over a 2.8 to 1 return on investment for plan sponsors, like employers or others who are investing in this virtual oncology model. What do you think drives those savings?
For
And why should employers invest in this model? That's a
yes.
that's what-
So, I mean, honestly, we now work mainly with employers and health plans because it's been also a big problem for them. A big problem because they see the problems of their members facing in cancer, but also it's a big cost problem that they're trying to address. Our belief and my personal belief is like today you can impact that cost while still being completely non-compromising on the patient's care. Like you can give great patient care and still like reduce the cost of that care on the plan or on the employer, on whoever is paying for it. And that's been our approach, and that's why we believe we can create savings. The savings come from 4 or 5 different things. One, when you catch cancer early, obviously, like it's a completely different outcome, both in cost and survivorship, right? Like a stage 1 breast today compared to stage 4, a lot less expensive, like probably 30% the cost of a stage 4 and like 95% plus survival rate. So but to the question you asked before, like we try to compress the time to diagnosis. We get people screened. Because we do that, we catch cancer earlier, which saves money for the payer because they're paying less for that treatment. Two is when you do multidisciplinary tumor board for everybody and you're making sure everybody is always on the right treatment, you're reducing the cost of the second line, third line therapy, or like an inefficient treatment or a wrong diagnosis or a wrong treatment plan. And we see that in our own care every day. Like we had a patient who was completely misdiagnosed, like was diagnosed as a pancreatic cancer. It was actually a cholangiocarcinoma, different treatment, different chemo, different prognosis. When you do that, you save money because you're catching problems before they happen with the patient. That's the second way. The third way, I mentioned survivors. Like survivors are a very complex population. If you manage them well, there's data out there that shows that survivorship clinic, and actually virtual survivorship clinic specifically, reduces the medical claim costs of the patient and medical utilization by the patients because now they're well managed proactively. That also saves money. And we're not a fee for service model, like so we're not billing every single service we offer the patients. It's a bundle. So the employer comes and pays color a bundle for 6 months of care for a treatment patient or like a survivor. And then it's unlimited care, unlimited access in those 6 months. That also reduces the cost on the plan because they're not having to pay the fee for service, every time they have to do an intervention. And the last thing I say, like we also impact the cost of the drugs because today there's different ways you can get the same treatment, and it can vary a lot in the cost of that treatment. So we help with that as well. So those are the 5 ways I would say today that we save money for a plan, and across those 5, that's how we estimate our return on investment for them, basically.
So, what excites you the most about the next 5 to 10 years in oncology innovation?
Look, honestly, I think it's 2 things. One, like there's going to be there actually, like if you look at the pace of the drugs coming into market and the pipeline and the innovation, there's a lot of promising therapies and promising treatment coming. And if anything, it's going to continue improving the lives of people with cancer. I don't know if you saw, there's like this new drug for pancreatic cancer stage 4 that was just given like
Accelerated FDA. Yeah.
actually FDA approved review and compassionate use permission. But there's a lot of these drugs today that are making a big difference for patients that are coming to market. There's also a lot of diagnostics coming to market. Like if you think about liquid biopsies, like Galleri tests or Shield tests, etc. There's a lot of innovation on the diagnostic side. There's a lot of innovation on the treatment side. But with that innovation comes, as I mentioned, like more complexity because these are not medications or diagnostic tools that are going to be great for everybody at the same time. Like they need to be applied to people with specific risk profiles or specific problems or specific situations or diagnoses. So that's what excites me because I think first of all, it's going to give a lot of patients a great opportunity to live a great life after cancer and through cancer. And it's creating a challenge because how do you make sure everybody can access those in a great way? And that has been always a challenge in healthcare. And I think that's what makes me excited because I think we are playing a key role here. We're the first virtual cancer clinic. I do think this model can actually allow a much faster way to get patients the drug that they need and the treatment that they need and that they deserve. and expand, and do that loop very quickly. Like that pancreatic cancer drug, like we already are talking with our own patients about it, like literally the day after. And that's like a completely different pace of moving from a potential to an outcome very quickly. So that's I think what makes me excited about this and the challenge ahead. And at your point, it's a new model. There's still a lot to figure out and how you make it work well, how you make sure patients are always getting the right care, etc. And that's what we're doing every day. So that's what makes me excited about it.
Yeah, and I think what my hope is like right now with a lot of the cancer drugs are so expensive, and the hope is with AI helping in the development of these drugs, maybe you'll develop them cheaper, and so you can have access to. Because right now it's not fair, right? Like you have people who are live in very rich countries have access to some of these cutting edge medications, while people who live in much poorer
Yeah.
countries will die from the cancer because they will not have access to this medication.
Yeah, and I think AI is going to accelerate a lot the generation of like actual like drug and medication in cancer that's expected. I would say like I also like I would share with you a stat to confirm the same thing you're saying, but I think in like 95% of new drugs in cancer that got approval from the FDA in the past 2 years were like more than $100,000 a year in cost. So
Right.
it's, but I think that's also why you want to make sure that you have the right people on the right drugs. Because again, like when you're going to pay that much money, you need to make sure it's the right people who are getting it and and then you need ways to make it accessible for them. And I think that's where we can make a big difference. And I think that's also where I'm hopeful there's going to be new models of delivery of these drugs that actually help people get access to them in a more affordable way.
Right, that's an important point. I mean, you need to get the biggest benefit from the drug. If you give it to someone who is not benefiting from it or it's
Yeah,
not indicated for, then it's just a waste for everyone
yeah,
and for the
yeah,
patient.
yeah.
What has surprised you the most working in this space?
I think like like we all say healthcare is broken and the system is broken. I don't know. I feel like I haven't really realized how broken until I started working with patients directly in the space because it's insane. We went to medical school, right? Like we learned, guidelines, etc. Like, you have an abdominal fit test, you need to do a colonoscopy, it's a potential cancer. And then I get amazed by how many times this doesn't happen in real life, and I'm like, how? And I'm sure because it's not like people are not well intentioned or people are not doing the right thing. Everybody doing the right thing. It's just the way the system is set up is creating so many places where just patients fall through the cracks and then gets forgotten until somebody remembers or like they show up in the ER. And that feels like I guess like maybe it's not surprising as in I know all of us know about like the system not being great, but it was just surprising to me to what extent it was when I started seeing what patients go through and what gets forgotten or not done. Like or a patient like has an abnormal scan and the physician doesn't do anything with it, and then you find out 2 months later that they had a cancer. Like a lot of the cancer narrative has been when you hear patients talk about it is all of these like missed opportunities, like oh and many of them have this regret like, oh, I wish I pushed more on this thing that I was feeling or I was hearing or I saw in my imagery, but I didn't. So I think like that was surprising to me of like I think there's more missed opportunities right now in healthcare for many patients. And cancer is tough because cancer time matters, right? Like, if you don't act quickly, it gets worse. So you need to act fast. So these missed opportunities are more costly. So I guess that's been probably for me the thing that I was more surprised about of like how widespread this is and how it's sort of also to my point earlier is not necessarily specific to a rural area or something. Like it's even people who have care in great places. And I think with cancer too, just because the change in the prevalence and incidence of cancer and it getting younger, maybe we're all not, we're not ready for it. It's like if you have a 40-year-old or 30-year-old coming to you with like symptoms, cancer is not the first thing you're going to think about. But then if it ends up being cancer, there's like a lot of like, like, oh, I wish I looked at it differently. I think that's been the most interesting thing for me. And we don't know why this is changing, right? Like we don't know why that trend in cancer is changing. And it's going to be hard to, if we don't know why, we can't change it. So that's been probably my most surprise, my surprising part. And yeah, and it's hard for the people who go through it. So, but
Nice. Now I'm going to ask you a personal question. What advice would you give people who want to work in the field of like healthcare innovation and AI, or who want to be like you?
yeah. Look, I honestly like I don't know, maybe I'm biased right now because I'm in it, but I do think it's one of the more exciting times in healthcare because I think between the what AI can bring to healthcare and the problems we're seeing in healthcare, and also the options for people to own a lot more of their healthcare. Like if you think right now about all the wearables and how you live every day, like you have more ownership as a patient of your own health and your own decisions. I think we're like at this point conversion between, the people wanting more and expecting more and feeling they are empowered to do more with their data and their health, the system not really working well and reaching a breaking point, and then you have this technology coming in that can actually completely transform it. It's a very exciting time. I think what I tell people who are interested in this, like there's a lot of big opportunity there. Cancer is one of them. It's everywhere in healthcare. My push for anyone who wants to work in this, like go back to the premise of like put yourself in the shoes of the people and the patients you're trying to serve and what they're doing and how they have to go through the process of accessing care today, whatever it is you're trying to solve, and solve from that first, because ultimately that's what matters and that's what's going to help you build something great. You will always find another way to make work around, how you get paid for it, etc. But like you need that would be my big advice. Like I think there's a big potential in healthcare. There's a lot of problems. They all start with like bad outcomes for patients and people. So I don't know, it's exciting. I encourage people to go through it and really take one problem and solve it deeply. There's not going to be this magical solution that will solve everything. You need to focus on a specific problem, take it deeply and solve it deeply. But you can solve it deeply in a way that's very transformative for whatever you're trying to do. So that would be my advice.
Right, exactly. As your company, the company you work for, Color, has shown. Thank you so much, Dany, for being on the podcast. And hopefully people were able to learn a lot more about like AI use in healthcare and potentially virtual cancer care.
No, thank you for hosting me. This is my first podcast, so I hope it was fun for you too. But I appreciate the time. Thank you.
Thank you.